Hey everyone, and welcome to this highly structured board prep explainer. This is proudly presented by the Cineo Medical Association and authored by Dr. Daniel Hamoudi and Dr. Imin Biniache. I am absolutely thrilled to be your guide through this material today. Now, we all know that studying neurology for the USMLE, the NCLEX, or even your college anatomy courses can kind of feel like you're navigating a super dense forest, right? Well, today we are going to completely clear that path. We're going to break down these complex neurological concepts into a highly visual, high-yield format specifically designed to lock this knowledge right into your long-term memory. Let's dive in. Here's our game plan for today. We'll start with objectives and concepts, move into brain lesions in the cortex, hit cranial nerves, travel down the spinal cord pathways, dive into neuropharmacology, and finally wrap it all up with some USMLE pearls and a summary. Section 1. Objectives and concepts. High-yield foundations. So what are we really trying to achieve here? Well, our core learning objectives focus heavily on pattern recognition and localizing the lesion. Think about it. When a patient presents with a specific set of deficits, your brain needs to instantly map those symptoms to a very specific anatomical zip code. By the end of this explainer, you're going to have the exact tools and the high-yield mnemonics to do just that. Okay, let's clear up something right out of the gate that constantly trips students up, the difference between aphasia and dysarthria. The clinical correlation here is absolutely crucial. Aphasia represents a central, higher-order cognitive issue. We're talking about the brain's actual language centers being damaged. Dysarthria, on the flip side, points to a peripheral motor or a cranial nerve deficit. The patient knows exactly what they want to say, but the mechanical execution is slurred or defective, usually because of issues involving cranial nerves 7, 9, 10, or 12. Just remembering this one distinction will instantly help you localize between a cortical lesion and a brainstem or peripheral issue. Section 2. Brain lesions in the cortex, vascularization and deficits. When visualizing our cerebral vascularization, you've got your anterior, middle, and posterior cerebral arteries. Pretty standard, right? But I want you to really focus on those overlapping borders, the watershed zones. Imagine a state of severe systemic hypotension, say a massive heart attack where blood pressure just drops globally. These watershed zones are the furthest away from the main arterial supply, so naturally, they suffer infarcts first. And here is a massive example for you. Damage to these specific watershed areas classically presents as upper leg and upper arm weakness, but usually spares the face and hands. Sticking with the cortex, we've got to talk about two incredibly high-yield aphasias. First up, Broca's aphasia. This involves damage to the inferior frontal gyrus. The patient totally understands you, but their speech is non-fluent and honestly very frustrated. The absolute best USMLE mnemonic to lock this in is Broca's is broken boca, boca meaning mouth in Spanish. Then we have Wernicke's aphasia, which is located in the superior temporal gyrus. Their speech is totally fluent, but their comprehension is entirely impaired. The mnemonic you need here, Wernicke's is wordy but makes no sense, or simply Wernicke's equals what? Section 3. Cranial nerves, innervation and diagnosis. Now, descending into the brainstem, eye movements are just heavily tested. You've got 3 cranial nerves controlling your extraocular muscles, cranial nerves 3, 4, and 6. Please do not try to brute force memorize the anatomical tables for this. Instead, I'm giving you the ultimate exam pearl. Just memorize this weird chemical-looking formula, SO4, LR6, all the rest 3. That simply means the superior oblique is controlled by cranial nerve 4, the lateral rectus by cranial nerve 6, and literally all the rest of the extraocular muscles are controlled by cranial nerve 3. It's a total game changer. Before we leave the head and neck, we definitely have to touch on the mini mental state examination, or MMSE. The MMSE standardizes our physical exam steps, from checking orientation all the way to language commands. But here is the critical clinical correlation you actually need for the wards. A patient must have intact attention, that's step 3, before the rest of the mental status exam can have true localizing value. Think about it. If a patient can't pay attention to you, their failure to recall 3 objects 5 minutes later doesn't mean they have a pure memory deficit. It just means they were never paying attention in the first place. Section 4. Spinal cord pathways, tracts, and pathology. All right, picturing the cross-section of the spinal cord, you've got the dorsal columns located posteriorly. These handle your proprioception and fine touch. Then, anterolaterally, you have the spinal thalamic tracts, which carry pain and temperature. Now, if a patient suffers an anterior spinal artery, or ASA, occlusion, the blood supply to the front 2/3 of the cord is wiped out. This results in bilateral loss of pain, temperature, and motor function. But, and this is a huge board concept, the dorsal columns are perfectly spared. Why? Because they're supplied entirely by the posterior spinal arteries. There's an exact anatomical quote taken directly from our source material that I want you to literally burn into your mind. Legs are lateral in lateral corticospinal, spinal thalamic tracts. So why does this actually matter clinically? Well, if a patient has an expanding tumor pressing on the outside of the spinal cord and extrinsic compression, it's going to hit those lateral leg fibers first, which means you can predict that their lower extremities will show neurological deficits way before their upper extremities do. Section 5. Neuropharmacology, Receptors and Mechanisms. Let's zoom way in and talk adrenergic receptors. To master cellular pathophysiology on your exams, you can't just know what these receptors do, you have to know how they do it. The major exam pearl here is knowing the G protein pathways. Alpha-1 uses the GQ pathway. I always think of it as GQ for calcium Q. It activates phospholipase C, generating IP3 and DAG, which ultimately spikes intracellular calcium to cause smooth muscle contraction and vasoconstriction. On the flip side, the beta receptors, beta-1 in the heart and beta-2 in the lungs, both use the GS pathway, which stimulates adenylate cyclase to increase cyclic AMP. Section 6. USMLE Pearls and Summary. Let's quickly contrast two major movement centers, the basal ganglia and the cerebellum. Think of the basal ganglia as your autopilot for procedural movements. Pathology here leads to resting tremors and bradykinesia, classic Parkinson's presentation. The cerebellum, though, is the refiner of finely controlled movements. Lesions here cause intention tremors, that shaking that actually gets worse as you reach for a target. But here is your strict rule of thumb exam pearl. Cerebellar lesions produce ipsilateral signs, meaning on the same side as the lesion. Basal ganglia lesions, they produce contralateral signs, the opposite side of the lesion. Okay, let's run through a really rapid summary. Broca's is broken and non-fluent in the frontal lobe. Wernicke's wordy but fluent in the temporal lobe. Your eye movements, governed by SO4, LR6, and all the rest 3. Moving to the spinal cord, syringomyelia selectively damages those crossing spinal thalamic tracts, causing bilateral pain and temperature loss in the arms. Meanwhile, Tabes dorsalis, which is a late manifestation of syphilis, destroys the dorsal columns, resulting in a profound loss of proprioception. Seriously, integrating this neuroanatomy with physical findings is your absolute key to clinical mastery. And here are the incredible source files from the Sino-Medical Association that made today's review possible. Before we completely wrap up, I want to leave you with kind of a provocative thought. As we master these pathways, from the highest levels of the cortex all the way down to the exact G protein receptors, how far are we from a future where targeted neuropharmacology might actually be able to repair or bypass irreversible spinal tract lesions? Keep that curiosity alive. Keep localizing those lesions, and I'll see you in our next explainer.